I would be talking to you about management of acute hydrops, and this is the talk which I had actually given in World Congress Cornea in US, which was held last year, yes, in American Academy of Ophthalmology. So there are no financial or proprietary interests, and we all know that acute corneal hydrops is a tear which is there in the Descemet's membrane, followed by leakage of aqueous into stroma and epithelium, and there is marked corneal edema. The incidence after keratoconus is highest, but it can also occur after pellucid marginal degeneration, keratoglobus, Tyrion's marginal degeneration, and even after surgery such as LASIK, RK, DALK, and penetrating keratoplasty. Now, this was our study, the childhood keratoconus study of 116 eyes, and in this the incidence was 7.7%. This study was done at RP Center. The risk factors are eye rubbing, young age, it is more in males with steeper keratometry, vernal keratoconjunctivitis, atopy and Down syndrome, mental retardation and trauma. And patients will generally complain of marked decrease in vision, photophobia, pain and corneal haziness. Then there can be congestion, marked stromal epithelial and microcystic edema, intrastromal cysts and Descemet's membrane tear with or without detachment. So these are just some of the cases to show acute corneal hydrops in case of keratoconus, pellucid marginal degeneration, keratoglobus and post-RK keratectasia. So whenever there is ectasia, there can be this complication. And this is something that we published, acute hydrops in keratectasia after radial keratotomy. Then it can also occur after post-microbial, post-CXL keratitis. And this was again one odd case that we published. Now the investigations most important, I think, and easily available is anterior segment OCT. And you can actually see, you can also do ultra biomicroscopy, but it may not be available at all places. But that gives you the best resolution, and it helps also to plan the surgery and monitor the follow-up. Now we've also described what is called as the hydrops resolving index using a UBM, which is the ratio of maximum thickness of corneal edema at presentation vis-a-vis corneal thickness at a site 2 millimeters away, and it should be 0.8 to 1, and then you know that it is actually resolving. Now anterior segment OCT, it looks something like this. It identifies the Descemet's membrane detachment, depth of epithelial and stromal edema, intrastromal cysts and cleft, and helps you to plan the surgery and monitor the treatment. There are 3 patterns of Descemet membrane detachment: break with rolled ends, break and flat ends, and detachment with no break at all. And in the natural course, secondary corneal scarring would occur and healing will be there, but it will take about 4 months to happen. Now there are various treatment modalities which have been described. As soon as this case is diagnosed, you give medical management in the form of topical hyperosmotic agents, steroids, lubricants, antibiotics, cycloplegics, and topical anti-glaucoma drugs. As far as the surgery is concerned, people have used intracameral injection of air and gas, compressive sutures with intracameral gas injections, stab incisions can be given, even people have done endothelial keratoplasty, and some people also advocate that you can do an early DALK for these cases. Now, what is the role of intracameral gas or air? It is that it helps to reattach the Descemet's membrane to the stroma. There's faster resolution of corneal edema. It reduces the risk of corneal neovascularization and improves the chances of graft survival. You can inject air, SF6 or C3F8. Of course, repeat injections are required if you use intrastromal air. Then there may be rise of intraocular pressure with the intracameral C3F8, and endothelial toxicity may be an issue with SF6 or C3F8, but at that point in time you're not bothered so much about the endothelial toxicity, more bothered about the fact that it should close. So when you give intracameral C3F8, this is how it closes. And again here, this is yet another case. You can see how coalescence of these cysts have occurred after intracameral C3F8. And this is our case that we had, again C3F8 was used, but this was a case of pellucid marginal degeneration. The hydrops were somewhere here, and see how over a period of 2 weeks this has caused resolution. Now there can be non-resolution also, especially when you inject air or gas, because sometimes there may be fish egging. The cleft is so huge that these small droplets of the gas or the air, they have fish egging and they go intrastromally. Now, another method by which you can deal with it is the use of compressive sutures. So here, 4 full thickness compressive sutures are being used to cause apposition of the ruptured Descemet's membrane. And again, here also the signs of resolution begin at first week and complete resolution occurs by third week. Now then there are combined techniques of compression sutures with gas, and again the results, although there are not too many studies with too many cases, but they have been found to be good. Now what we described is AIOCMTC intracameral C3F8 guided C3F8 injection with stab incisions. So this is just to show how you look at the anterior segment OCT and you just see where the areas of the clefts etc. are, and then this is how it is done. So you give a stab incision, and after giving the stab incision the C3F8 is injected, and then just look at these dark areas. Where you see these dark areas, you give a stab incision. So actually the fluid is going to come out from those areas because they are nothing but the cystic spaces of the clefts from which the fluid is coming out. And this was also published. And this is just to show how resolution in the same case that I showed you is occurring over a period of time, and there is clearing of the cornea as well as the resolution of the acute hydrops. These are some, again, 3 cases. Notice this is such a huge keratoglobus with the hydrops, and that has also resolved, and these are the interstromal cysts which have coalesced. Now again, with the help of the intraop OCT microscope, it becomes a lot easier because you can actually see where you have to give stab incisions directly under the microscope, and you can give there, followed by the injection of the gas. And people have even done endothelial keratoplasty in anecdotal cases with good improvement in visual acuity. Now, why do you need to cause an early resolution of this? Because there may be corneal neovascularization, perforation, pseudocyst, fistula, scarring, etc. And when you have vessels, then there's increased risk of graft rejection. So you are actually preventing that. And this was one of our cases that we reported, acute hydrops with secondary bacterial keratitis. Again, scarring and neovascularization in this. This was a case where there was a corneal perforation in case of acute hydrops, which was glued. I think Pranita would remember this case. This was during her time in RP center when this was glued, and rather than putting a graft here, this thing, glue was used. Now, this is a review article on management of acute hydrops in ectatic corneal disorders. So to conclude, acute hydrops can be visually debilitating if not managed timely and appropriately. Air or gas injection is useful in these cases. Intrastromal drainage of clefts and cysts should be done. Microscope integrated and intraop OCT is a useful tool to delineate its morphology. Apposition may be caused by use of sutures or DM grafts, and early treatment is required to circumvent the complications. Thank you very much for your kind attention.